Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Moderna, Inc.
Hello, I'm Dr. Megan Pesch, Assistant Professor of Developmental and Behavioral Pediatrics at the University of Michigan Medical School in Ann Arbor, Michigan. There, I'm the Director of our Congenital CMV Developmental Follow-Up Clinic. Our podcast entitled Cytomegalovirus, Back to the Basics. It's part of our Let's Talk CMV series. Joining me today is Dr. Natalie Aziz. Dr. Aziz is a clinical associate professor of obstetrics and gynecology at Stanford University School of Medicine in Palo Alto. Dr. Aziz is passionate about education, especially about bringing more awareness to CMV during pregnancy. Welcome, Natalie. Thanks so much for joining me.
Thank you, Dr. Pesch. It's my great pleasure to be here today.
Well, first, Natalie, let's start off. Can you tell our listeners what is CMV and why is it important to know about CMV?
Of course. Well, CMV is a DNA virus, and it's within the herpes viridae group, which includes our common viruses like varicella zoster virus, herpes simplex, and Epstein-Barr virus. And similar to these herpes viruses, it becomes latent after a primary infection, but it can reactivate with renewed viral shedding. The other tricky thing about CMV is that it's ubiquitous. It may be present in blood, saliva, tears, urine, semen, vaginal fluid, stool, and breast milk. So basically, it's really everywhere. And shedding can occur from multiple sites and for prolonged periods. And we can even become infected with different viral strains. So not only can you get a primary infection, but you can also get a reactivation where the same virus resurfaces in your body, or a reinfection with a different strain. Furthermore, in addition to being so ubiquitous and present in so many of our bodily fluids, it can actually cause certain consequences or sequelae that are very important. For example, it's the leading cause of congenital hearing loss. In immunocompromised individuals, it can cause significant disease in different organ systems. And during pregnancy, it's associated with congenital anomalies if the fetus is infected, and especially brain development. The virus can also cause fetal growth restriction, fetal demise, and pregnancy loss during pregnancy itself. So it's a very important virus to educate not only all our patients, but especially our vulnerable patient populations, including those who are immunocompromised and pregnant individuals or individuals who are planning pregnancy. And it should definitely be a part of our prenatal education so that a patient may recognize symptoms or risk factors and that we can appropriately evaluate patients who may be exposed to CMV or infected with CMV.
You're totally right. Clinicians need to be aware about CMV and know how to educate. I'm so glad that you could join us to bring awareness to CMV and to help us all better educate our patients. So let's take it back to the basics. Can you explain to us what is the pathogenesis or pathophysiology of CMV?
Absolutely. And like the other herpes virus family, CMV basically establishes itself as a latent infection after the resolution of an acute or primary infection. And these infections lead to an immediate, early, and then late viral proteins. And these are usually detected in monocytes, dendritic cells, megakaryocytes, and myeloid progenitor cells in the bone marrow. The secondary symptomatic disease may present later in life of the host, and it can be either reactivation of the latent CMV or reinfection with a new strain. And finally, the reactivation of CMV may occur at any time during a person's life. So although the risk is higher during systemic immunosuppression, whether it's iatrogenic or secondary to an underlying medication or condition, this lends itself to having a higher risk factor for reactivation. And the majority of CMV disease in immunocompetent individuals is due to the primary infection. So fortunately, many of us don't have reactivation issues lifelong, but those who are immunocompromised are more at risk for this. And the other tricky or complex issue with CMV is that differentiating between a reactivation versus a reinfection is pretty difficult, since most labs don't have virus-specific serologies to detect the different viral strains of CMV.
So once you get CMV for the first time, it's latent, it's, in your body, it can be reactivated, but most of us just don't realize that, or, it doesn't become clinically apparent. That's really, I think, important to know. Can you discuss the importance of viremia and detectable versus undetectable levels?
Yes, absolutely. CMV viremia and also viuria are common, either due to reinfection or reactivation, and can occur lifelong intermittently through a host's long life. With viral presence, individuals again are infectious, and the infection is transmitted when we have either higher levels of the viremia or viuria. So it's definitely correlated with the frequency of viremic status, as well as the level of the virus that's being shed. Reactivation of CMV may occur at any time during a person's life, and although the risk again is higher in either a systemic immunosuppression period, but immunocompetent patients are also very likely to transmit sometime throughout their lives. It's nobody is immune to CMV reactivation once a host has actually been infected with CMV. So we have to really think of it as a lifelong process, just like we do think of, for example, the varicella virus or the herpes virus. These can reactivate at any time throughout our lives, and especially at times where we may be more immunocompromised than usual.
And so what are the clinical manifestations of CMV? Like what should people look for? What organs are affected?
Fortunately, for most of us who are immunocompetent, there's usually no symptoms or some few symptoms that may mimic a mild cold or a flu-like symptom. So they can include fatigue, fevers, headache, pharyngitis or rhinitis, lymphadenopathy, myalgias, and arthralgias. And this is interesting because I don't think many of us consider this, but rash is actually very common in CMV, and up to a third of patients may have some type of a rash, whether it's macular, papular, a combined form, or rubilliform or morbilliform, or even a scarlet tiniform eruption. In addition to the mild febrile illness and nonspecific symptoms, the important thing to remember is that although there are symptoms and signs for CMV infection, approximately 90% of cases may not be clinically apparent. So it's very important to remember that in terms of prevention and patient education. And even though these symptoms of, for example, a febrile illness or rhinitis, pharyngitis, and rash may exist in about 10% of the population who's infected with CMV for the first time, it's very important to remember that mostly this is a silent infection that occurs in individuals. And that's why it's important to educate our patients, especially those who are immunocompromised and those who are pregnant, regarding CMV prevention. In terms of organs that are affected, those would include the gastrointestinal system, the liver, the CNS, including brain and nerves, lungs, eyes, cardiovascular system, and especially for those who are pregnant, the placenta, which is an organ system during pregnancy.
I think I often forget about the placenta being an organ as a pediatrician. That's good to point out.
Yes, absolutely. And I can also elaborate a little bit on the laboratory findings. So again, elevated white count is common, thrombocytopenia, transaminitis, a mild or moderate anemia. And there can even be abnormal coagulation studies. You can see reduced heptoglobin levels. There's cold agglutins that are detected. There's also elevation of rheumatoid factor, and you can see positive anti-nuclear antibodies as well. So it's quite an interesting infection in which many of the laboratory studies can mimic other disease processes. And I try to really reinforce that during pregnancy, for example, when we do have thrombocytopenia and transaminitis, and when most of us are thinking of the HELP or preeclampsia syndromes, I always tell our colleagues that, please remember that CMV is also part of this differential diagnosis and definitely affects pregnancy.
So Natalie, can you elaborate and tell us a little bit more about how CMV is transmitted?
Yes, being the ubiquitous infection that it exists throughout our bodily fluids. So including cervical and vaginal secretions, semen, blood, breast milk, nasal mucus, saliva, stool, tears, and urine. So it's everywhere, and it has multiple routes of transmission. So these bodily fluids are often in close non-sexual contact settings like a household member, household activities, and occupational exposure. There's also sexual exposure. There's transfusion-related exposures, and that's why we always will transfuse pregnant women with CMV negative blood. Finally, again, very important to remember that the route of transmission is also transplacental in a pregnant woman.
So who tends to get CMV? Are there then groups that are particularly at high risk for CMV or CMV complications?
That's a great question. And we can all get CMV, basically. So immunocompetent hosts, immunocompromised hosts, transplant patients, again, pregnant women, and of course, fetuses and babies in the neonatal period. So if we think about these, we try to think about who has the most risk of being around a CMV infected person. So we know that children and being a mother or daycare worker or, for example, a pediatrician, we have more contact with children. So daycare providers, families with a young child, healthcare workers, immunocompromised patients, families with CMV shedding members, especially those with younger children, are some of the highest risk groups for acquiring primary CMV or a reinfection with another strain. There's also other socioeconomic status factors that have been determined have been female minority adolescents, for example, and individuals who may have high number of sexual partners and have unprotected sexual activity. Those who are at most risk of developing disease processes to different organs are those individuals who are immunocompromised, including transplant patients and fetuses, because in utero, the fetus also does not have a mature immune system, and therefore, given that CMV primarily attacks the neurologic system and the placenta, so this can lead to multiple neurologic congenital issues, as well as growth restriction and fetal demise.
So really to hammer it home, any pregnant person who has these risk factors is then at higher risk of having a baby with congenital CMV. That's an important link coming from the pediatric side. So then how do you reduce your risk of CMV or having a baby with congenital CMV?
I think those are really good questions. And standard of care at this time is really to educate our patients and to make behavioral risk reduction interventions. So with pregnant women, we try to remind them that, especially if they have younger children that are going to daycare or are actively involved with other children that may bring home CMV. So having a good hygiene model might be an idea in terms of hand washing with soap and water after contact with diapers, trying to, again, avoid oral or nasal secretions. And if we do have contact with that, to have wash hands at least 15 to 20 seconds, trying to not share food or oral utensils, and obviously keeping surfaces, toys, countertops very clean, and using disinfectants that will help reduce the spread of CMV that may be in just saliva of a child that is just touching the countertop. And for, again, that also applies to women who may care for young children, whether it's a teacher or a childcare provider. I think they should always be educated about CMV, especially if they're pregnant, in terms of keeping good hygiene and keeping it in mind to avoid close contact. And of course, there's healthcare workers as well, and the same applies.
So in some ways, CMV can be an occupational hazard for certain occupations. I think your point about standard precautions is really great. Since COVID, I think we have all kind of realized the importance of hand hygiene and even more. But the risk to women who or people who already have children at home, I think our guards often get dropped. When you're at home, your guard is kind of let down. You're in your own safe little bubble. So I think your point is really important about for people who are at home with young kids to, not let that guard get let down, and really watch out for those exposures that, can be commonplace.
It's hard to stay, contact-free from a beautiful little baby that you have, or a child who's 4 years old and coming home from nursery school, for example. But it is important, and I think you bring up a really good point, is that perhaps maybe putting up our highest guard when we are in our preconception mode and in that first trimester and early second trimester, because the earlier a pregnancy is infected with CMV, the more sequelae and the more likely that there will be neurologic outcomes if the fetus is infected. And I also want to just reiterate your great point about, our resetting of our standard precautions and our mindset when just in public as well, with respect to our COVID experience and how COVID has reminded us that we really need to keep those standard precautions, always in place.
So to summarize, what are some of the key takeaways that a clinician listening to this today?
Obviously, our clinicians have all been educated about CMV and have a certain knowledge base, but I do think that CMV is definitely one of those infections and diseases that can just be somewhat not recognized as quickly as we may think. So take home message to our clinician colleagues from today is that CMV is very common. It's present in so many bodily fluids, and it can affect a wide range of organs. It's, quite a hidden infection. In 90% of individuals, again, it's typically asymptomatic. And fortunately, in healthy adults, it's self-limited. And if it is symptomatic, it can often mimic a mono-like picture or a viral upper respiratory tract infection, or maybe a rash or a dermatologic condition. So I think keeping it in the forefront of our differential diagnosis in these situations, when someone persists or comes in with a persistent prolonged fever, for example, or has a transaminitis that we just can't figure out, and all our hepatitis serologies are all negative. I think it's very important to keep CMV as importantly a priority in our differential diagnosis as we do Epstein-Barr virus or hepatitis B or C. And it can have significant sequelae in the vulnerable patients. Our vulnerable patient populations are the immunocompromised and fetuses or pregnant patients who may get fetal infection. So CMV should certainly be considered in individuals with those types of protracted fevers, transaminitis, mono-like symptoms, and it's definitely a topic that we should be, as physicians, we should be including in our preventative care and prenatal care discussions with our patients.
Awesome. Thank you so much for joining me today. I know many of our listeners are probably wondering, what do you do about CMV or how do you test for it? And that is something that we will dig deep into in a future episode. But for now, I really appreciate your insights about why it's so important to educate. And thank you for taking the time to be here with me today.
Thank you. It was a pleasure. Thank you so much.